Welcome, dear colleagues. Today there's an EHRA webinar on mapping and ablation of persistent atrial fibrillation. I'm Professor Isabel Deisenhofer from the German Heart Center in Munich, Germany. The aim of this webinar is to give you a better understanding of innovative techniques to map and ablate the substrate driving persistent AF. And just to give you an overview, that is a simplified scheme of what we think that atrial fibrillation is caused by. And these techniques to map the substrate include driver and rotor mapping, voltage mapping, and even ganglionated plexi mapping. But today we are going to talk about electrogram-based mapping. So we are going to present you a first mapping that is based on the visual assessment of electrogram dispersion in 3D mapping, based on sequential multi-electrode recordings. And these recordings were done during ongoing AFib. In this study, the electrogram dispersion is a marker for an AF driver, and thus it's a target for an ablation. These cases will now be presented by Dr. Julien Seitz from Marseille, France, and later on Dr. Tom de Potter from Aalst in Belgium will present you some very interesting new data on a whole atrium mapping approach where electrograms recorded from a basket catheter are assessed to identify regions of interest that could perpetuate atrial fibrillation. At the end of this 60 minutes live event, you will have insight into electrogram-guided mapping of AF, and you will have gained insight in the results of such electrogram-based ablation approaches. This session is intended to be highly interactive, and we strongly encourage you to actively participate. Please send in your questions, your comments at any time during this webinar through the chat. For the best learning experience, we also invite you to participate in the online assessment. During the session, there will be some multiple choice questions, and you can submit your answers during the presentation. Anything you need to know, just ask, and we will provide tips and tricks for your daily clinical practice. This webinar is possible thanks to an educational grant from Biosense Webster. And now I will hand over to Dr. Julien Seitz. Please.
Thank you, Isabel. Dear colleagues, I'm very happy to be here, and I would like to thank the European Society of Cardiology and Biosense Webster for the invitation. So here are my disclosures. I would like to start with a case. This patient was a 70-year-old man with previous myocardial infarction. He has a long history of paroxysmal AFib since 2000. He experienced PVA isolation in 2006, but unfortunately underwent paroxysmal recurrences after PVA isolation. And this paroxysmal AFib became persistent since 8 months. The patient was symptomatic with dyspnea, and he has a decrease in his left ventricular ejection fraction to 40%, and his left atrium was moderately dilated. So the first question is, what is your strategy? Choice A, this is a persistent AFib. Ablation will probably not be effective, and the guidelines are not very clear, so I propose a rate control strategy. Choice B, the patient is symptomatic with a left ventricular dysfunction, and so I propose a rhythm control strategy with a new ablation procedure. Make your choice.
So I think it's an interesting question. So it's the old question, rate or rhythm control, and please submit your answers. And here are the results. So 15% of our audience think that this is a persistent AF and rate control strategy will be sufficient. And the overwhelming majority, 86%, think that the patient is symptomatic and rhythm control strategy with a new ablation strategy should be pursued. So I think...
So this is also my choice. So we do the ablation procedures, and at the beginning of the ablation procedure, you observe a reconnection of the left pulmonary veins. So the question is, what is your ablation strategy? Choice A, you perform a new isolation of the left PVs, followed by DC cardioversion if the patient remains in AFib. Choice B, you perform a new isolation of the left pulmonary veins, followed by cafe ablation with automatic softwares and lines, the stepwise approach. Choice C, you perform a new isolation of the left pulmonary veins followed by a panoramic rotor mapping and ablation with Spatio system, ECGI, or other system. And choice D, you perform a mapping and ablation of AFib driver based on dispersion mapping, followed or not by PV isolation.
Yeah, I think it's a very interesting question, and our audience has already decided. So it's a more mixed image. 32% tend to version A, so only re-isolation of the left PVs and nothing else. 13%, so the minority, thinks that we should do then a stepwise approach following this re-isolation. For option C, it's 6%, and for the option 4, for D, so mapping and ablation using dispersion, it's the majority, it's 53%. So
great.
I think people want to hear what you have to tell them.
Okay, so this is my choice. So why perform AFib ablation and here without PV isolation in persistent AFib? To my opinion, the first argue to this question is that PV are not necessarily active in persistent AFib. This is a study we performed a few years ago, and we measure the cycle length inside the pulmonary veins and inside the left appendage before any ablation. And very interestingly, you can see that in a proportion of patients of 40% in persistent AFib and in a great majority in long-term persistent AFib, PV were completely passive with a longer cycle length and sometimes silent PVs. So this data for me is important. But today, I think that the definition we use at this time of active PV was very bad. Of course, we cannot be sure that only because we record a short cycle length inside the veins, it implies that these veins were active with a driver. So let me show you now another data very important to my opinion. When we talk about active PVs, are they really active? In this study that we recently published in the JACC EP, we performed the same mapping in the pulmonary veins and in the left appendage, before ablation here and during substrate-based ablation without PV isolation. And very interestingly, you can see here that in this patient, we could imagine that the pulmonary veins were active in AF perpetuation with a shorter cycle length than recorded in the left appendage. And although we observe very rapid activity with rapid fires, and 110 milliseconds recorded inside the veins. So we believe at this time that we had drivers inside the veins. But very interestingly, you can see that without performing any PV isolation, just ablating in the left atrium, we observe an increase of the cycle length in the left appendage progressively, but also in the pulmonary veins, and a disappearance of these rapid fires. So in this patient, in my opinion, this data prove that the drivers were not located inside the veins, but in the left atrium. Okay, concerning the results, to my opinion, PV isolation, and not my opinion, I think we all agree that, on this point, that PV isolation has very poor immediate results in terms of AF termination. You can see here 11% and 8% in the Star AF2 study. So acute results, immediate results are really poor in terms of AF termination. If we look at the long-term results in persistent AFib, Star AF2 study showed that in these 3 arms, all these patients underwent PV isolation. More than 500 patients underwent PV isolation, and you can see that after multiple procedures, only around 50% of all these patients were free from any arrhythmia at 18 months. So PVI has poor long-term results in persistent AFib. So after Star AF2, the question is, should we only ablate paroxysmal AFib and do PVI, or can we do better in persistent AFib ablation? So new technologies for the automatic visualization of AFib drivers have been developed recently with very interesting results. You can see here the Spatio system and the ECGI system. And Sanjeev Narayan in 2012 and Michel Sager in 2014 has published very excellent articles showing good data, interesting data, with 56% of termination with Spatio and 63% of termination by targeting drivers, and it was 80% if they add lines. And they also have very promising long-term results. So this publication opened a new way of thinking in the field of AFib ablation and in the field of mapping drivers. But visual appraisal of the sequence and morphology of intracardiac electrograms is sufficient to guide ablation of most arrhythmias. Atrial fibrillation is an exception to this paradigm so far. Several authors have specifically pointed out that fractionation occurring in a non-simultaneous fashion at neighboring electrode locations, what we could call time dispersion, and organized in well-defined cluster, what we could call spatial dispersion, may indicate the presence of an underlying source of AFib. You can see several examples of very interesting, fascinating publications from the Bordeaux group first, with also Sanjeev Narayan and Dr. Ganesan and Gorani, New York, and of course recently very interesting article from Amir Jadidi and Thomas Arends that show that regional activation was very important to detect AFib drivers. So let me show you now the results of the Substrate HD study that was published this year in the Journal of the American College of Cardiology. For a long time, we used to perform classical cafe mapping and ablation with a quadripolar ablation catheter. But since we start using multi-electrode catheter like pentarray, we realized that we've missed something very important. And what we missed was the analysis of the regional activation. Because as you can see here on this slide, at the location of an AFib driver, you don't observe only continuous cafe, but also other types of electrograms. And that's why we decided to merge the analysis of cafe to an analysis of activation in this region to create what we call spatio-temporal dispersion. So dispersion areas were defined as clusters of electrograms either fractionated or non-fractionated that displayed inter-electrode time and space dispersion at a minimum of 3 adjacent bipoles such that the activation spread over all the AFib cycle length. So let me show you a few examples of electrograms that can be recorded from dispersion region. You can see here examples of single bipole analysis. Of course, we often recorded continuous cafe, as first described by Wina Demani. But we can also observe non-continuous cafe, as shown here, what we call trains of fractionation. But we could also non-fractionated, but with very short cycle lengths, what we call rapid fires. And here you can also record non-fractionated and non-rapid electrograms that observed independently doesn't seem very interesting, but if you look at its neighbor, it seems to be a reentry-like pattern. So here are some examples of electrograms. You have here dispersion region without fractionation. This electrogram seems not to be very fractionated. And here a bystander region, when some of the electrograms seems to be fractionated, but not continuously, of course. This one is the dispersion region with continuous cafe, but not only continuous cafe, as like shown here. And this one is, of course, a bystander region. This one is a dispersion region with the whole cycle length is recorded, but all the electrograms are fractionated, but not continuously. And here, of course, this is a bystander region. So let me come back to the first case, the first patient, this persistent AFib for 8 months with low left ventricular ejection fraction. So we start the procedure by performing left atrial mapping with pentarray catheter. So this movie is accelerated. The speed is not the natural speed, but in the real life, we try to move very slowly our pentarray catheter and to have a very good contact of the splines on the left atrium wall. And so we perform we create the LA shell, and we select visually electrograms that show dispersion, and we point out. We tag with clusters of white dots this area of dispersion on the 3D geometry. So we try to go everywhere in the left atrium, everywhere, to have a good contact and to map each part of the atrium. But we also map the right atrium at the beginning of the procedure, because we need to have a precise roadmap of what we have to ablate to obtain a biatrial dispersion map, very accurate, and we try to go everywhere with a good contact. That's very important before starting any ablation. So you can see here examples of, sorry, I have to go back. Okay, so you can see here examples of electrograms that we observe in this case. This one was a bystander region with without dispersion and sometimes a few low level of fractionation. You can see now a driver region with a high degree of fractionation. I'm sorry, the video. Okay. Okay, so you can see here a high degree of fractionation and of course a dispersion. And you can see here on the next slide, you can see low voltage electrograms, low voltage with dispersion and with fractionation more or less. So we start the ablation and we ablate only this region of dispersion. So we burn here and we adapt our power settings to the contact and to the location. We try to eliminate all the electrograms and to create a complete scar. And as you can see here, we ablate this part of the dispersion region and terminate AFib into a stable tachycardia. And this tachycardia corresponded into a peritricuspid flutter that we ablated successfully. Then we induced a new tachycardia that we mapped with our pentarray. So I will show you the activation map right now. This tachycardia corresponded into a roof-dependent left atrium flutter, as shown on this propagation map. And so, of course, we decided to create a line on the roof to terminate this tachycardia, what appears just now. Okay, so finally, we ablate AFib drivers. We ablate 2 tachycardias. You can see the pink dots corresponding to the sinus rhythm conversions. And you can see that the procedure was not very long, 2 hours and 20 minutes, 45 minutes of radiofrequency, and 40 seconds of fluoroscopy. So let me show you now the results in our population. 105 patients compared to a control group for 47 patients ablated in a conventional way with the stepwise approach. 80% of persistent and long-standing persistent in both groups. The both groups were, of course, comparable. Importantly, you have to know that in long-standing persistent AFib, we usually do not interrupt amiodarone in order to help us, and none of these patients experienced previous AF ablation. So here are the acute results of these studies. You can see here the AFib termination rate, which was very superior in our approach than in the stepwise approach, and the sinus rhythm conversion rate, also better in our group. Interestingly, we have better efficacy with shorter procedure in our group, less radiofrequency time and less fluo time. So finally, we can say that this approach has a better efficacy with less extensive ablation. So let me show you now another case. This is a 60-year-old woman with a short-standing persistent AFib since 5 months. She underwent a wholly patient-tailored ablation a few months ago in our center, and she comes back with palpitation and dyspnea. So this is ECG. The first question is, what do you think? Choice A. This first ablation was a complete failure, and this recurrence is due to the pro-arrhythmogenic effect of this substrate-based ablation protocol. And choice B, this is a recurrence, and I don't like recurrences, of course, but persistent AFib often need more than 1 procedure to be ablated. Make your choice.
Yeah, I think that is really something we are confronted with every day, and I think in that case you can be depressed, of course, but yeah, we have the results, and I think the majority of our audience is a little bit thinking like we are, then, because only 8% think that this is has been a complete failure, and that this is just a pro-arrhythmic effect. And 95%, I'm sorry, it changed. It's 5% only. 95% think that this is a recurrence, but President AF often needs more than one procedure.
Great. Yeah, of course, that's what I think, as you. And the other question is, what is your strategy then? First choice, she's more symptomatic than when she was in AFib. I change my strategies for a rate control strategy. If the drugs don't work, I will ablate the AV node and implant a pacemaker. Choice B, I keep my initial rhythm control strategy and program the ablation of this tachycardia.
Yeah, that's the again, rate versus rhythm control after first attempt of rhythm control. And yeah, I'm curious. We wait a little bit for the results to come down. Okay, so it's 33% think that she's more symptomatic than she ever was in AFib, and we should change to a rate control strategy. But 67% think we keep on with this rhythm control strategy and program the ablation of this atrial tachycardia.
Okay,
so we'll go on.
So now last question. What is your opinion concerning AT recurrences following AF ablation? First choice is these tachycardias are due to the pro-arrhythmogenic effect of ablation, and we should not ablate more than what we know how to do, PV isolation, in order to avoid such very symptomatic arrhythmias. Choice B, AT is a step between AFib and sinus rhythm, and if atria are not able to fibrillate anymore, that means that we have been partially effective. And choice C, we do not know the exact mechanism of this attack, stabilization of AFib substrate that unmask AT and or a pro-arrhythmogenic effect of ablation. You can make several choices in this question.
So here it's pretty divided. So 8% think that these ATs are a pro-arrhythmic effect of ablation, and we should not do more than PVI, only 8%. 52%, so the majority think that AT is a step in between and is halfway to sinus rhythm. And 40% think, I'm not sure what it is. It could be the one or the other, and it's not clear. So.
Okay. So I choose B and C. Okay, so let me show you the ablation of this patient. So we perform an activation map with pulse array in the left atrium, and as you can see here the propagation. You can see area of scars, maybe pro-arrhythmogenic, I don't know, and you can see re-entry re-entry activity here and here, maybe a double loop, maybe a figure of 8, and so we ablate only this region. We didn't check the veins, we didn't check anything, we just ablate the tachycardia. We ablate here, and we terminate this tachycardia very quickly. So this case was very simple. Of course, not all these tachycardia are so simple. We have sometimes very complex case, and it's difficult, and we have to deal with several tachycardias. But here it was very simple, and this is a good example to show that this patient was not inducible anymore at the end with a very short procedures. It was only 30 minutes and a few minutes of radiofrequency. So if I had ablated the AV node and put a pacemaker in this patient, that would have been, I think, a bad decision, because this arrhythmia was very simple. Okay, so let me show you now the 18 months follow-up of the patient in the Substrate study. After one procedure, you can see on this slide that the freedom from any arrhythmia, AFib or attack, was 55%. It was better than in the control group, but the difference was not impressive. The difference is better and more important after multiple procedures. You can see that after 1.4 procedures by patients, we have 85% of patients free from any arrhythmia, and patients with persistent and long-standing was the same results. So I think, to my opinion, this patient must have radio ablation if we want to have good results. Let me do a comparison with Star AF2. This is not very scientifically correct, but let me just show you, if we look at the persistent and long-standing persistent cases in our study compared to the Star AF2 study, you can see that we have better results after one procedure, but the difference is, again, not very impressive. But the difference is much important after multiple procedures. And very interestingly, if you look at the type of recurrence, you can see that in our group we have an important ratio of 80 AF recurrence. And to the opposite, Star AF2 had very low proportion of 80 recurrences. And if you look at the success rate after multiple procedures, we can imagine that this patient with 80 are this one who are in sinus rhythm, and this patient with 80 are this one in sinus rhythm. And of course, ATAC are much easier to ablate than AFib, which is a complex arrhythmia. So you can see here the procedure time and the radial frequency time. First procedure of AFib, second procedure, third procedures, and of course it's more and more simple and more efficient. So in case of recurrence after a persistent AFib, we prefer, of course, ATAC than AFib. We love ATAC, of course. And let me finish just with this paper, published very recently, I think it's last week, by the Bordeaux Group and Pierre Jaïs and Dr. Yamashita. Very interesting paper. You can see it was, they performed a mapping with ECGI in persistent cases. And this example shows two areas of drivers, here one on the anterior wall and one on the ridge. So AFib drivers here and here, they start the ablation by ablation this driver on the ridge and organized this AFib into an atrial tachycardia. And when they mapped this tachycardia, it was located here on the first AFib driver. So they observed the same results in a large cohort of patients. 82% of the localized ATAC they observed were terminated within an AFib driver region, and in 39% in unablated area. I think these data are very important, and I have to tell you that we have exactly the same results in a publication that is not completed, but we have, with a different way of mapping, exactly the same results. So, to my opinion, AT are usually not induced by ablation, but unmasked by ablation and are part of AFib substrate. So, to conclude, dear colleagues, spatio-temporal dispersion of electrograms represent an electrical footprint of AFib drivers. The clustering of intracardiac electrograms exhibiting spatio-temporal dispersion may guide a wholly patient-tailored ablation for AFib, especially for persistent AF. We had a good AF termination rate within 20 minutes of radial frequency. Using this approach, we do procedures are mostly performed for AT recurrences that are much easier to ablate than AFib, what led to promising long-term results. MRI scar distribution and voltage map are very interesting in the future to maybe add information to dispersion map. Of course, a better lesion creation and assessments like Ablation Index and other tools are very important. These preliminary results must, of course, be confirmed by a randomized trial. This is very important. And finally, automatization is, of course, very complex, but absolutely needed to detect dispersion. Thank you very much.
Thank you a lot, Julien. I think this was fascinating data and food for thought. We have some questions from the audience, and I have selected one which I think is maybe a little bit at the key point. Is how is this ablation approach different from cafe ablation, which has been shown in randomized controlled trial not to be effective? And that's maybe the key question. So what is different from the classical cafe ablation or mapping?
Okay. First, the Star AF2 study was performed with automatic software that detect cafe, and I think the software are not very effective. They're not specific at all, and so I think the software are not effective. As I just tell you, using multi-electrode catheter add other informations than only the fractionation morphology of electrograms. And I think it's very important to note that, of course, the majority of electrograms in driver regions are fractionated, of course. That's why Nademani has this result for a long time, and he's very effective. But we can also have other electrograms in this region, non-fractionated ones, and we can also observe CAFE in bystander regions. So the discrimination between active CAFE and passive CAFE is very difficult, I think, to my opinion. So this patient allow us to have maybe a simpler definition. If you record the whole cycle length in a region, CAFE or not CAFE, we don't care. If you have the whole cycle length, this is a driver, and you have to burn here. And fractionation depends on local frequency. So in case of very fast AFib, you can have CAFE everywhere, and a lot of passive CAFE. And in case of slow AFib, in case of redo or amiodarone, I don't know, you have less CAFE, and you can see re-entry pattern. So I think CAFE mapping in the classical way is difficult to do, very difficult.
Yeah, thank you. I think that's a very good answer. Another thing is, you mentioned it already in your slides, this old discussion, is ATAC just an effect of our, is it the complication, atrial tachycardia, is it the complication of our AFib ablation or not? I think you could very conclusively show that it's more or less a sort of an unmasking of something already there that is just hidden by the AFib and might then come out. Yeah.
Of course.
Yeah. Yes. If there's no more question, I don't know, Tom, no? Okay, then maybe we go on to the next presentation. And thank you again, Julia. So this is Tom de Potter, who will present his very, very new results and share with us some innovative technology for whole atrium mapping. So that means that in contrast to Julien Seid's technique, you do not map sequentially with a multi-electrode catheter, but you map with one catheter the whole atrium at once.
Okay, let's try to get the slides up and running. Good evening from my part as well. If we could please have the slides for the second presentation. What I would like to share with you tonight is the insights we have gathered so far from a slightly different, however, sometimes strikingly similar approach to what you have just heard on mapping of persistent atrial fibrillation. So my presentation as well, I would like to start with a case presentation, a case of a 62-year-old male that presents without any significant cardiac history or risk factors and presents with de novo persistent atrial fibrillation. Initially, he's treated with a pharmacological strategy, flecainide beta blockers, and is cardioverted back to sinus rhythm, which holds for 5 months. And 5 months later, the patient presents with a recurrence of persistent atrial fibrillation. So as a question to the audience, I would like to ask, what is your strategy in this clinical vignette, which you should be able to recognize, which is not so uncommon? A, would you repeat the DC shock and see if you can win again a few months for this patient? B, would you perform a pulmonary vein isolation? C, would you offer rate control to the patient? Or D, would you consider non-pulmonary vein ablation?
I think it's an interesting question, and it's as you said, it's a relatively common clinical setting that you confront us with, and I'm curious to know the answer of the audience, and we're almost there to have a look. So we have these 4 options, and 10% opted for version A, so repeat the DC shock. I'm sorry, 12%. 60% would do just a PVI isolation. 8% rate control, and 18% non-PV ablation.
Okay, very good. So Dr. Seitz clearly managed to convince some souls, and I would like to share with you some more data. That, of course, supports the majority of your vote first, the majority choosing PV isolation. And we know from randomized trials that PV isolation is, first of all, a successful strategy. There is 60% success rate, for example, in the randomized controlled Pst AF2 trial for PVI alone. And of course, more importantly still, the additional strategies, the debulking strategies, let's call them, in these trials, the Pst AF2 trial, the BOCA trial, for example, that aim to offer more, did not show this result. They did not result in more success, in a better outcome. And this is, of course, a puzzling question, because there is also contrasting data. There is data from, for example, the CONFIRM trial that reports successful ablation, termination of atrial fibrillation with very limited ablation sets. And you've just heard from the excellent work of Dr. Seitz what can be achieved with ablation, not even doing PV isolation. And finally, if you look at the data from the debulking strategies from, for example, the linear ablation strategy, you will see that the best results are achieved in those patients that actually respond very early in the linear ablation lesion set, so not after the complete debulking has been performed. And to explain this discrepancy a bit, I've taken this slide from a recent publication that basically illustrates the difference between two schools of thought. One of them, the more conventional multiple wavelet theory for atrial fibrillation, for which a mass debulking strategy would be required if you would have to have success. And B, another school of thought that suggests that there may be localized, spatially stable regional mechanisms of atrial fibrillation, drivers of atrial fibrillation, that if you can identify them, you can target them and ablate them. And of course, if this is true, it makes sense to do targeted ablation for this kind of pathology. And if this is true, it makes no sense that very limited ablation would be successful. So to illustrate this a bit more, I would like to start by sharing with you the type of data we can gather from multi-electrode mapping. And this is an example of what we call panoramic mapping. Panoramic mapping means we put a catheter in the chamber and try to map as much of the chamber as we can simultaneously with one beat or with several beats, but with all the electrodes together. And what you can get from this, and I hope you will agree with me that it can be intuitive, is if you focus your attention first on the right part of the screen, which is the left atrium, if you focus your attention on the activation pattern, and if you look at how the wavefront propagates, I believe you will agree, if I hint you to it and you have some imagination, you will agree that here at the base of the appendage, and it will turn into view right now, there seems to be a repetitive pattern. There seems to be a counterclockwise rotating repetitive pattern there. And if you look on the left side, which is the right atrium, you can see a much more macro reentrant type activation, an activation that seems to be much more compatible with what could potentially be right atrial flutter. If we put catheters in these patients, we can indeed confirm that we do observe different types of rhythms or different expressions of arrhythmia in different locations of the atrium. For example, in this patient, we find atrial fibrillation on our intracardiac catheters in the left atrium, in the right atrial appendage, in the coronary sinus. However, in the left atrial appendage, which is recorded on the ablation catheter in this tracing, we find a highly organized rhythm. We find a spectacularly regular rhythm, despite the fact that the patient is clearly in atrial fibrillation. We find strikingly different cycle lengths as well. We find a cycle length of 140 milliseconds in the left atrium versus a cycle length of 200 milliseconds in this left atrial appendage. And again, look at how organized this rhythm is versus the chaotic fibrillation on the other electrograms. So coming back to this case, coming back to this 62-year-old man with as I have shown you now, at least we could argue, I cannot prove to you what it is, but at least we could argue that there seems to be something that may be of potential interest. Let's call it a potential region of interest at the base of the left atrial appendage. Atrial fibrillation with this mapping and with this region of interest. And now, for the purpose of debate, and it's not invented, this is a patient from a clinical trial. Let's assume this patient is in a clinical trial for mapping these regions of interest in persistent atrial fibrillation. What would be your strategy? Would it still be PV isolation, option A? Option B, would it be targeted ablation at the anterior base of the left atrial appendage? Option C, cavo-tricuspid isthmus ablation, or option D, DC shock and PV isolation?
Yeah, so I'm curious to know the answers to this question. And in fact, we have it already. So 21% would opt for PV isolation only. 67%, and so the overwhelming majority, two-thirds of our audience would do a targeted ablation at the anterior base of the LAA. C, the CTI ablation is 4% and 8% for DC shock and PV isolation. So I think option B was voted for.
Glad to hear that most people seem to believe we can try to at least perform science on these patients, and we did actually do what you suggested. As a matter of fact, we first performed cavo-tricuspid isthmus ablation. One, because we saw this macro reentry pattern in the right atrium. Two, because the catheter was in the right atrium initially. Three, because we believed to be this cavo-tricuspid isthmus ablation would not result in immediate termination of the atrial fibrillation, because the left atrium seemed to be the driving region to us. So it made sense to us to do it in this sequence. And we did perform cavo-tricuspid isthmus ablation, after which we performed focal ablation at the base of the left atrial appendage, which did indeed result in termination of the atrial fibrillation and transition to atrial tachycardia. At this point, we saw a rather curious tachycardia originating from the left superior pulmonary vein with a cycle length of 180 milliseconds and a 2-to-1 conduction to the left atrium, cycle length in the left atrium 360. And here I show you what happened after we isolate the pulmonary veins to illustrate this tachycardia to you. After isolation of the lateral pulmonary veins, you can see the atrial tachycardia in the left superior pulmonary vein unaffected, still ongoing, where you can see non-tachycardia in the left atrium. Here it is still an ectopic atrial rhythm, but this converted to sinus rhythm a few minutes later. You can see the atrial tachycardia at 180 milliseconds ongoing in the left superior pulmonary vein, and the ectopic atrial rhythm, distal CS first, in the left atrium, converting to sinus rhythm moments later. Now, what I've shown you, this patient and other data I will show you, is data collected from the FIND-EU and the Rapid AF trials, trials that are industry-driven and are designed as prospective non-randomized trials, evaluating a new system for mapping and ablation of non-PV targets in persistent atrial fibrillation. The goal is to include patients that either never underwent ablation or have had a single pulmonary vein ablation, isolation, without additional ablation that failed, meaning the patient has recurrence of atrial fibrillation after the pulmonary vein isolation. And from a technological perspective, what we've done in these trials is to try and identify repetitive activation patterns, region of interest, whether it is a rotational pattern, whether it is a focal source, using a multipolar basket catheter, initially using the commercially available Constellation catheter, the 64-pole Constellation catheter in the FIND-EU trial, and then later, due to deficiencies we observed and we were faced with due to the design of this catheter, a dedicated specific investigational catheter was developed, a 192-pole catheter that has CE label in Europe now, that is used in the Rapid AF trial. The Rapid AF trial ongoing in 4 sites in Europe, 2 sites in Canada, 1 site in the UK, opening soon. And what we are doing in this trial, what we are trying to do is to algorithmically approach this atrial fibrillation and to provide these maps that I've just shown you by trying to determine the local activation time during atrial fibrillation on the unipolar recordings of the electrodes of these basket catheters. The outcome of such a process, of course, is that you are able to annotate an entire sequence of activation, an entire single shot or panoramic activation of a particular chamber during atrial fibrillation. And once you have this, you can represent this, of course, visually in what is called a 4D LAT map, 4D because the time component is integrated. How this looks like visually is like this. You start, of course, with raw data, with recordings, and from this raw data, I think you immediately appreciate that a purely visual appreciation of these signals is going to be hard simply due to the fact that there is an overwhelming amount of data present once you start collecting these recordings. So what happens is the algorithms behind this system annotate the atrial activation, annotate where the atrium lies, and can then represent this annotation in a fashion that we are all used to in a activation map on a 3D mapping system. So here you see a very simple example, of course, of sinus rhythm in an animal model. Here you see a sinus impulse originating from the sinus node region, and then the propagation of this sinus beat, craniocaudal activation of a normal sinus beat. So behind this algorithm is a rather complex mathematical system to be able to annotate these signals. In a first step, what happens in this system is that ventricular far field is removed from the unipolar recordings. Important to note is that the ventricular far field is removed. The ventricular period is not blanked, which means the system still annotates atrial activation underneath the QRS. The ventricular far field is simply removed from the unipolar tracing. And then in a fashion quite similar to the wavefront algorithm, a bipolar window is constructed around each potential atrial unipolar recording so that a window of interest is created where annotation can take place, at which point atrial annotation of unipolar recording takes place and is scored along using mathematical models called wavelet analysis to allow accurate annotation of the unipolar recording. Now, the result of this, of course, is that we get a local activation time for every electrode simultaneously. And the other result is that we don't have a reference electrode. We don't have a reference electrode to which the annotation needs to be compared. Because we are using panoramic mapping, we don't need to stitch the map together. We can simply use the time as the reference. The external time is our reference, which is time 0, which means, of course, that every activation will be negative. Every event will happen before now. Nothing can happen after now. This would be the future, and we don't know what will happen next, but we can observe what happened before now. Meaning every activation, every LAT is going to have a negative value. And if we simply wait a bit and let the map continue, the time will move to here, but no new event will have taken place. So simply every point will get a more negative local activation time until it expires, until it is no longer projected on the map. So visually, this looks like this. Here you see an example of a 3D model with a window, a color window representing now, here, 0 milliseconds, up until 300 milliseconds ago. And you can see that an event happened almost 300 milliseconds ago. It is colored in blue, and when we click to the next frame, when we go to the next event, you can see new events are starting to enter the color window. New events are starting to happen, which will be represented in red, which means that basically what is red on the 3D map represents the developing wavefront, represents the activation wavefront of the ongoing activation pattern of the particular rhythm you are studying. So as an example, in a very simple model of arrhythmia, right atrial flutter, what you see here is a typical counterclockwise activation in the right atrium. Again, if you follow the red wavefront, if you follow the activation pattern of the red wavefront, you can appreciate the counterclockwise activation going over the roof, lateral wall of the right atrium, across the isthmus, the tricuspid valve, and coming back up along the septum, along the interatrial septum. This is this same type of arrhythmia, this same right atrial flutter now mapped from the left side. So here you see a map of the left atrium, and here you can see a typical example of passive activation. What you see here is a wavefront that develops clearly from here, from the entry of the wavefront, which is of course the right atrium. Impulse enters the left atrium through the septum, through the CS, and you can see the wavefront passively developing across the left atrium until the lateral wall of the left atrium. Of course, these are not arrhythmias we are studying with this system in the study protocols. What we are studying is atrial fibrillation, and the two typical mechanisms we find is one, this pattern, rotational activation patterns. Here is an example of a rotational activation pattern in the right atrium, and the interesting thing about visually presenting this in this type of maps, in this type of color-coded maps, is of course that once you have identified something that you consider a potential region of interest, then it becomes feasible to go look at the electrodes. Now it becomes feasible to say, show me the electrodes around this region, and let's have a look if, first of all, there are no artifacts, if we did not misannotate anything, and second, if we find exactly what Dr. Seitz has just shown you, if we find progression, linear progression of activation, if we find a linear sequence of activation. And it's exactly what you see here, of course. You see over these electrodes a linear activation sequence of atrial events that are not misannotated, that are not due to artifact. So we have strong confidence that what we are seeing here is an actual event, is actually happening. The other interesting phenomenon that we observe is, of course, focal activation, a focal activation pattern, a point source spreading in every direction, which is clearly a candidate for a region of interest, which is potentially a driver region for arrhythmia, for atrial fibrillation. And again, here we can start identifying this visually and then focus our attention on the electrograms that generated this color map, that generated this pattern, and see if they are true, see if they are existing in real life. And of course here what we are looking for is an electrogram pattern where we find a single exit point, a single focal origin, a single first electrode that then drives all the other electrodes, and that repeats itself cycle after cycle over and over again. The same electrode is the first electrode. Such a system is visually very intuitive and very nice to use. It does come with limitations, limitations which I would like to illustrate with a second case. A man of 68 years presenting with hypertension, hypercholesterolemia, and has paroxysmal atrial fibrillation since a few years, also treated with flecainide and beta blockers, initially successfully, but after a few years, the patient progressed to persistent atrial fibrillation, initially still with a spontaneous cardioversion after about 2 weeks, but then a few months later, the patient again developed persistent atrial fibrillation that this time did not terminate spontaneously. And this map I'm showing you for several reasons. First of which is that I would like to illustrate to you that not all these maps clearly show us what is going on. And this is an example of a map where I think you need a lot of imagination to see repetitive patterns. And even if you do have a lot of imagination, I would still find it challenging. At least we in our clinical procedure did not clearly identify repetitive patterns, did not clearly see patterns that were repeating over and over again, except for this region, this very small region where you see ablation points at the lateral wall of the right atrium. This was ablated without any effect, and then according to study protocol, we did not see an effect on the atrial fibrillation. We continued with pulmonary vein isolation and cavo-tricuspid isthmus ablation. We performed this very limited ablation in the right atrium single target region, and we performed PV isolation and cavo-tricuspid isthmus ablation without any acute effect. However, a few minutes later, after finishing the ablation without any further intervention, this event spontaneously happens. What you see here clearly is ongoing atrial fibrillation, still disorganized rhythm, terminating straight into sinus rhythm without transition to atrial tachycardia. So clearly we did something, despite the fact that we did not necessarily identify the driver, and this can be due to several reasons. There are limitations in the approach we are using. One of them is that, of course, we only have information from what we cover. We only get information from the regions that we can reach, and with the basket catheter, this means we may have challenges or problems with the coronary sinus, with the appendage and the epicardial surface. It may be problematic if we use very low density mapping catheters with few electrodes and catheters with a very small footprint. For this, I believe a good solution was developed. We now have a 192 electrode catheter that was developed and overcomes these issues. But the second issue, of course, is what I have shown you. All this information is qualitative information. It is highly subjective. It may be subject to interpretation, for which a quantitative assessment is highly needed, what Julien also already mentioned. And something we are working on, the last thing I would like to show you, is algorithmic identification of regions of interest. For example, an earliest QS pattern. As you see here, this is work from Atul Verma's group in Canada, work he did together with the other FIND-EU investigators, developing a system that automatically identifies a region of interest, an automatic identification, let's say, of a focal pattern, of a QS pattern on the catheter. This was studied and validated. We studied both focal activation patterns and repetitive activation patterns that we try to identify using these electrogram criteria that I've shown you. And what was shown and what was presented at this year's HRS is that such an algorithm is rather sensitive, at least for focal sources. It performs quite well, performs reasonably well for repetitive activation patterns in the left and right atrium, and it showed very good agreement between the individual independent operators that judged these patterns. So in conclusion, I think our data supports the observation that we can perform panoramic mapping during atrial fibrillation, that it is feasible and provides reproducible data. Biatrial mapping studies have provided observations that may support these truly local mechanisms, spatially stable mechanisms in some forms of atrial fibrillation. Technological evolution has allowed high-density full-chamber mapping today with the 192 electrode basket catheter, and the FIND-EU and FIND-CANT studies are in the analysis phase. Unfortunately, I cannot share clinical data with you. We still aim to present these, obviously, and the Rapid AF study is ongoing. Thank you very much for your attention.
Thank you, Tom, and I think it was a highly interesting presentation that you could share all these results with us. Unfortunately, we're a little bit running out of time. I have only one question from the audience, maybe, and that's a question to both of you. How important is the right atrium in all this, in your findings? Very, very short answers, please. Please, Julien, maybe first.
Okay, we ablate in the right atrium in 50% of the patients.
So not so much.
Sometimes only a small region, the proximal CAS, but I think the right atrium is more important than we used to think.
Okay, perfect. And Tom?
It's clearly important. We map both, and if we feel we need to go to the right atrium first, we go to the right atrium first, and we clearly achieve success by doing even only right atrial ablation. It is clearly important.
So we have to leave this prejudice of the only left atrial arrhythmia when we cross AFib. So we are now approaching the end of this very, very innovative and very interesting webinar. I want to thank all the speakers, and I would like to close this session by reminding you some key messages of this webinar. I think we've shown that electrogram-based mapping techniques for persistent AF is now an option. It's a rapidly evolving field. We had today close insight into two new, very innovative methods to assess those electrograms in order to identify possible AF ablation targets, and I think that's something we're all interested in. Thank you again, Julien. Thank you, Tom, for your absolutely interesting presentation, and thanks to Biosense Webster, who supported this webinar with an educational grant. And I hope that all of you enjoyed this time with us, and you will be able to view all this again offline in a few days on the EC website to cross all these nice images again. Thank you again.
Thank you, Isabel.
Thank you.